This is Joshua English for the Alameda County EMS audio podcast.
One of the other things is that there are a lot of different things that trigger asthma attacks for people. It's smoke, environment that's got mold in it, dust mites, cockroach poop.
Alameda County has a disproportionate share of asthma patients. For this reason, we brought back Mike Tagman to talk about an asthma assessment and education tool designed to help patients with asthma better understand the triggers and to help mitigate environmental factors that exacerbate asthma. Mike, why don't you start out by telling us about the inspiration that led to the development of this asthma assessment tool?
So probably one of the inspirations for getting into asthma stuff at all is that I have asthma. So it's one I have a fair amount of experience with. Personally, I remember my first asthma attack. I was 5 years old and I went to YMCA sleepaway camp. I grew up in Colorado, and at the night of the camp, it was just one night of being at the campsite, but we sat around a campfire making s'mores, the marshmallows and chocolate and stuff in between. Graham crackers melted, which tasted pretty good. But sitting next to the campfire, I got a whole lot of campfire smoke blowing in my face. And when it came time to go to bed in the sleeping bag that night, I basically had what I remember as an entire night-long nightmare of being smothered in my sleeping bag and, being suffocated, basically for the entire night. And I was sick, vomited all over my sleeping bag, was, apparently too scared to let anybody know about it. They could tell I was pretty sick in the morning, put me on the bus, back home, with a trash bag to puke in. I got off the bus when I got home. My mom thought I looked pretty sick, took me to the pediatrician's office, who said, whoa, we need to go to the hospital. And I spent 2 weeks in the intensive care unit. Didn't get intubated, but that was back then when they used intermittent positive pressure breathing treatments and an oxygen tent and all that kind of stuff, which I have fairly vivid memories of, even though that was 45 years ago for me. And going to work in this community, realizing that, when you take a look at the health data for our community, got a lot of asthma in Alameda County, particularly in Oakland and West Oakland in particular. And there are a lot of theories about that. Port of Oakland with diesel ships, belching diesel fumes, all these trucks coming in, and they're, the law says they're not supposed to idle for more than 30 minutes, but they'll idle for 10, 12 hours, while waiting for their, load to be unloaded. Diesel forklifts, got the highways coming through there with all the air pollution associated with it. We've also got an ethnic mix in our community, and asthma is one of those diseases that hits some ethnicities higher than others. Actually, Puerto Ricans have the highest asthma rates, according to a fair amount of research. So there's a lot of need for asthma care in our community. One of the other things that is kind of nice about asthma is asthma's disease that responds pretty well to good self-care practices. If you do the things necessary to care for yourself, you can decrease your asthma attacks and really improve your life all the way around and stay out of ambulances and stay out of emergency departments and stay out of the intensive care unit. So it seemed like a good place to start, kind of on the path of helping EMS move from, we spend our lives sitting around waiting for bad stuff to happen to people, and then we go out and do an assessment and care for them and take them to the hospital and wash our hands of it. We're done, and we go around waiting for the next bad thing to happen. And I don't think there's a paramedic or EMT in this county that you talk to and you say, you ever taken care of the same patient more than once? Most of us have got, many of them we can name and recognize and know their whole story about folks that we've cared for a lot. And, in this country, close to 70% of healthcare dollars are spent on people with chronic disease. And most people with chronic disease don't interact with the healthcare system or the 911 system until, they've gotten fairly sick. Now, this is about kind of having us at a grassroots level help contribute to healthcare improvement and at a very frontline level, do our own little version of healthcare reform, which is not just patching people up and getting them breathing better, but really equipping them with the ability to care for themselves in such a way that they don't need us in the emergency setting in the future. So that's kind of the inspiration behind it.
So this is a collaborative effort between folks at the Public Health Department, including Emergency Medical Services and AMR. And why don't you talk a little bit about how the Public Health Department, AMR, and various community groups came together? What was the genesis of this partnership?
In Alameda County, there are 83 organizations that work on asthma in one way or another. And the Ethnic Health Institute, which is Dr. Frank Staggers, Joyce Gray, Dr. Michael Lenore, put together, they really brought, all the asthma folks together to really kind of look at what's going on in the community. So one of the first things we did is, rather than try to reinvent the wheel, let's go talk with the people who are already doing the work. Met with them. The Ethnic Health Institute has been working with the Alameda County Health Department and cooperation to figure out what are the opportunities for improved asthma care in this community. So one of the things that we've identified is that if you're under 18, there are great services available. There's a program through Alameda County Health Department, which is called the Asthma Start Program. And these folks will come out to your house. They'll do case management. They'll do teach you how to use your medications, do all this kind of stuff for you to really help you get better control of your asthma. And the early data from that group indicates that they've produced great results. Significantly more than half of the folks that they've done work with have dramatically decreased the number of times they've had to come to the emergency department, which is wonderful because it translates to those are kids that are not missing as many days of school, that are able to play with their friends, that get to have a fuller life than people who aren't caring for their disease as well. If you're over 18, there's not really a lot of services for you. So one of the things that we've done is we put together an asthma team to really fill the gap for the services that are available in the community. So we've got a group of EMTs and paramedics. The initial batches from AMR, certainly a wide open invitation from anybody from any of the fire departments who wants to participate. I've trained them in kind of the basics of asthma management. You need to have your own self-care plan. Everybody's asthma is a little bit different. So you need a self-care plan, usually designed in conversation with your physician, the physicians that are caring for you. You need to know how to use your medications. Like 90% of people with asthma don't know how to use their inhalers correctly. The use of the inhalers is not intuitive. Most people have both a maintenance inhaler and a rescue inhaler. And the maintenance inhaler is used differently than the rescue inhaler. For the rescue inhaler, you really need a spacer involved in order to be able to make the medication deliver well. Most people don't carry the spacers with them. We've identified a small size spacer that people can carry in their pockets with them. So there are a number of things that can be done to help people really learn how to take their medications properly. One of the other things is that there are a lot of different things that trigger asthma attacks for people. It's smoke, environment that's got mold in it, dust mites, cockroach poop, strong perfumes, strong colognes. There are a whole number of things that can trigger asthma for folks. So it's helping people identify what are the triggers in their environment and working to remove them. So cleaning up the mold, covering your pillow with plastic wrap so that the dust mites, it's estimated if you've had a pillow for over a year, more than half of the weight of the pillow is dust mites. I know, it's a great image to think about, isn't it? And we used to think that synthetic pillows had less dust mites than feather pillows. It actually turns out they have more. So covering them in plastic, covering the mattress in plastic. If it's a child, getting the kitty litter box out from underneath the kid's bed in another part of the house. Talking Uncle Earl into smoking outside rather than smoking in the home. Parents who love to hang the clothing on the line outside to dry during high pollen times. All that clothing collects pollen. If you're allergic to pollen, you put it right around your face. That's an asthma trigger. A whole bunch of little things that can be done. Switching, if you use dryer sheets in your dryer, don't use the ones that are perfumed, because that perfume can be a trigger. All of those kinds of things can make people's asthma worse. So it's about kind of going through the environment and really helping clean out the things that cause asthma attacks. And then also teaching people how to do a self-assessment of how they feel. There's a green light, yellow light, red light coding system that people can use to kind of rate their own asthma. How many times they're using their rescue inhaler, if it wakes you up in the middle of the night, can you hear audible wheezes when you're walking around, how many steps can you walk up before you have to stop and take a breath, those kinds of things, so you kind of know where you're at. And adjust your medications and your actions accordingly. Of course, if you end up in the red zone, you should be calling us for help. So that asthma team is available, and we just day before yesterday worked with Dr. Hearn and a couple of the fellows at Highland to design a research study using adults who visit their emergency department. With half of them getting the asthma team's intervention and the other half not, to track what the long-term impact of this is. So we believe it'll make a difference, but we don't know until we study it.
So the numbers are pretty staggering for West Oakland and the disproportionate share of asthma patients that they have. Is the focus of this project going to be mainly in West Oakland?
The asthma self-care team will certainly take care of people any place in the county.
Now, are the paramedics and EMTs that are going to be on this team, are they going to receive any extra training?
They actually have been trained by the Alameda County Health Department's Asthma Start team. So the folks who have been doing for years the visits and have produced such good results for kids, they're the ones who have trained our team. Our team is going to go out and do home visits with them and get real good experiential training and coaching. And they've agreed to help continue to mentor and supervise us in the process to make sure that we're doing the best kinds of things we can for the folks we're helping.
Wow, this really sounds like the future of EMS.
I hope it is. And as Peter Drucker, the management theorist, when he was asked, so what's your prediction of the future? His answer was the best way to predict your future is to create it. And this is part of creating our future, I believe. So the next part of this is, not everybody will necessarily be referred to the asthma team. And not everybody who has an asthma attack ends up in an ambulance. But for the ones that we do treat in the 911 system, one of the things we've added in, and Dr. Sinai Kadani helped put together this asthma assessment and education tool, which is basically a one-page sheet designed for paramedics to use with patients while they're transporting them to the hospital after you've given them a breathing treatment, and the patient's work of breathing is easier. They feel more comfortable when they're open to getting a little bit of coaching and feedback. We want to walk through this tool, which is really designed to assess how much they know about caring for themselves, and also provide a little education as part of the assessment process. So we're kind of doing two things at the same time. And Dr. Kanani spent a lot of hours dealing with lots of research and different tools to kind of synthesize this together for us. Our intent is to complete the tool, and then we're going to put it on NCR paper, so there'll be one copy that stays with the patient, so that the asthma educator or nurse or discharge planner at the hospital, respiratory therapist, whoever's going to work with the patient, has a heads up on how that patient's doing as far as their asthma self-care knowledge. The other copy we're going to bring back to us for some data analysis and collection, so that we can better understand the profile of people's asthma in the community. And if the patient goes to the asthma team for help, they've got an information to start with. So I'll just tell you, I'm not going to read the whole form to you, but I'll give you a couple of the things that are on it. It asks you, how were you diagnosed with asthma? Did you have a lung test with a pulmonologist, or was it primarily based on your symptoms? Asks you about what are the things that trigger your asthma, and has a list of those. Do you smoke, or anybody else smoke in your household? When I was a kid, my pulmonologist, when I first got diagnosed with asthma, he refused to treat anybody that smoked. If you wanted to be, and he was a great physician, if you wanted to be part of his practice, you had to quit smoking before he would treat you for your asthma.
Did you quit smoking?
I quit my smoking at age of 5 and haven't smoked since. It's true. Asked about if there's anybody else in the home that has asthma. Asked how often you've been in the emergency department. Have you ever been intubated? People who've been intubated once for asthma are high risk for needing to be intubated again. Asks a lot about medications. Ask you to show, how do you use this particular medication? Do you use the spacer? If not, can we give you one? Basically, have you run out of your medications ever? If you've run out of them, how long have you been out of them? Do you have an asthma plan? That kind of information. So it really becomes a template that an asthma educator or somebody who's there to work with somebody to help can kind of walk through and help build competency and capacity. One of the other things we're exploring, we haven't quite got it together yet, but many people, if not most people, have cell phones these days, and we're exploring the possibility of using text messaging as a way to support people remembering to take their maintenance medication. So that's still in early phases, but it's something we're interested in exploring.
Well, so has the team been deployed at this point?
We haven't made any visits yet, but the team's been trained. They're doing home visits for the adolescents with the Asthma Start team, and we're working with Dr. Hearn and the folks at Highland to be able to design the study before we actually start rolling that part of it out. And of course, we'll involve Dr. Pointer and Dr. Garrick here from the health department to make sure they weigh in, to make sure everything. We want to make sure we're really kind of forging new ground here, and we want to make sure that we do it with a crystal clear patient-centered focus, and that we're doing things that are appropriate and blend well with the rest of the healthcare system. So we're trying to make sure everybody's involved and part of the conversation as we move forward. And we've also got leadership of the health department, folks from the Ethnic Health Institute, which they've got members from all the hospitals in the area, all the community groups, all the schools of medicine in the Bay Area, all partnering with us to make sure the program that we're piloting produces the best possible results. It's really a community-based effort. People in the community taking care of people in the community.
So you haven't collected any data yet?
Not yet.
Well, last time we talked about how innovative the airway checklist was, and I'm interested. Is there anyone else in the country or in the world doing this kind of preventive care in EMS, as far as you know?
Actually, there is one group. It's through the University of Pittsburgh, group called eMed Health, and they actually their Highland equivalent in their service area is called Braddock Hospital, and at Braddock Hospital, I talked with the CEO of the hospital, and he said, he's got a population very similar to ours in his service area, a lot of asthma. He says, I've got kids that come into my emergency department every week, and they get admitted like once a month. They end up in the ICU every couple of months, sick with asthma, all kinds of issues at home. I treat them, and I keep treating them, and it's costing me tons of money. They're still sick. They're suffering a lot. Some of them have ended up dying. That doesn't seem okay. I don't have the capacity to deal with it myself. So he worked with the folks. It's called eMed Health. I think it's www.emedhealth.com. Or Google it, either one. You can find out information about it. But they worked with EMTs and paramedics with their local fire and EMS agencies and developed a plan to do something very similar to our asthma team. So they went to people's homes and did the asthma self-care plan, taught them how to use their medications and whatnot. Their data is yet to be published, but it looks like they've decreased emergency department visits by just north of 70%.
This is all very exciting, and it just makes me wonder about the fact that there has to be some other areas, the big major illnesses that affect our population. There has to be other ways to apply this same concept to help those folks as well.
Absolutely. I think asthma is a good place to start. Diabetes certainly makes it to the list. The management of diabetes is more complicated. To be, the balance of, all the different kinds of insulin, all the different ways that insulin can be administered, the use of insulin pumps these days, the balancing with nutrition and stress, exercise, sleep, all those things that really need to be in harmony in order to be able to manage diabetes, make it more complex. But I think there are things that we can absolutely do to help support diabetics in improving their self-care. I mean, every paramedic who's worked in a community for more than a year has woken up the same hypoglycemic person with D50 2 or 3 different times. And when you look at diabetes in particular, complications of diabetic retinopathy and blindness, the lower limb amputations, renal failure, MIs, strokes, secondary to hypertension. Most of those complications result from the fluctuations in blood sugar. High fluctuations in blood sugar cause these microvascular tears, which is what causes the organ damage in all of these systems. So if you can stabilize the fluctuations in blood sugar, you can, it's like 90% of diabetic retinopathy is preventable with good glycemic index management and early assessment and diagnosis. Same with amputations. And paramedics can be taught how to do diabetic foot exams to identify people who are at early risk for problems with that. So there's certainly things we can do that way. Congestive heart failure is another one. Elderly folks who are at risk for falls. Falls, again, it's a little bit more complicated than asthma. There are 3 major contributions to falls. Medications, strength, balance, and mobility, and then environmental factors. Environmental factors are pretty easy to fix. You pick up the throw rugs, you put a bright piece of tape at the top and bottom of staircases and those kinds of things. But the medications, strength and mobility, vision issues, those kinds of things that contribute to falls, they're more complicated to address. I think we can do a lot for those folks. But that's one a little further down the line. Sickle cell anemia is another one. If you've taken care of somebody in sickle cell crisis, and a pretty intense amount of suffering, there's a lot of pain, shortness of breath that goes along with sickle cell crisis. And there's some self-care things that you can do that decrease the chances that you're going to end up in crisis. So I think what we're going to do is look for the things that really respond well to prevention and self-care. Really encourage people to get their blood pressure checked. Encourage people to know what their cholesterol is. Encourage people not to smoke. Wear your seatbelt. Respond to potentially violent issues in your community with something that doesn't aggravate it so you don't get shot. All of those kinds of things are ways that you can decrease the chance that you'll be a customer of the 911 system. And I think that we should be interested and open to really being a partner in community health improvement in a way that's bigger than taking care of the STEMIs and strokes. We're still going to do that, and we're going to do that aggressively and really well. And adding this other competency to it, I think we can really be the core of this, not necessarily the saviors, if you will, but core contributors to healthcare reform and improving the health of the communities we serve.
It seems to me like this is an area where EMS can have a very big impact on the overall cost of delivering healthcare, on the quality of care that people receive. In so many different ways, EMS can have a very large impact on the upgrade of the healthcare system here in the United States. Are there any folks on the national level in EMS working to help to inform the government on the possibility of EMS going from a solely emergency response to also having a preventive role as well.
I've heard that there are some efforts, and I'm not really involved in the national kinds of issues. I do participate in the Institute for Healthcare Improvement, and they've got a really loud voice in Washington. I'm going in a couple of weeks to their national forum, and we've got some dinner meetings with collections of EMS folks who are attending and participating in that meeting with some of the leaders of IHI to make sure that they don't think that healthcare starts at the door of the hospital, which tends to be a prevailing mental model in healthcare. We're helping them open that up and trying to get that to happen. And there's the think globally, act locally. Alameda County has got some amazing people thinking about how do we improve health right here at home. One of the really interesting programs to me, the Ethnic Health Institute has been traveling back and forth to Cuba. I think they just went on their 7th trip to Cuba. I think actually Dr. Garrick may be there right now. And they're studying how people in Cuba approach healthcare. And one of my favorite examples came back, in the U.S., when the dental hygienist comes to the junior high school and does the little class on brushing and flossing, and then leaves toothbrushes and those little tin samples of floss, and then they hope for the best. In Cuba, when the dental hygienist comes to the school and they do the class on brushing and flossing, kids go to lunch. When they come back from lunch, they all brush and floss under the supervision of the person who taught them. And then every day they're in school from that point on, when they come back from lunch, they all brush and floss together. In a country that's a poverty-stricken country, that only spends $240 per capita per year on healthcare, as compared to our almost $9,000 a year on healthcare, they have better dental health than we do. So it's really benchmarking, going to find places that seem to have figured things out and bringing them back and seeing how it impacts our community, what we can learn. One of the coolest things about living in this community, in this county, people are really open and really interested in solving problems at a grassroots level. I forget the name of it. I think it's the East Oakland Community Health Improvement Project. It's funded by the California Endowment, where they're doing a 10-year place-based health project, where all these community leaders are meeting, doing strategic planning every other week, and getting together, and they're talking about things like, grocery stores in neighborhoods. If you're hungry for dinner and you don't have transportation and the closest thing you can walk to is a liquor store, then dinner is Coke and a bag of chips. And it's a public health issue that you can't get an apple and a carton of milk. And they're regular people in the community coming together with, people from the health department and other, health issues, faith-based leaders, all coming together and all working at a real grassroots level about what are we going to do to take care of our community? What are we going to do to take care of ourselves and improve our health and our living conditions all the way around? I've worked all over the place, all over the U.S., Canada, many places around the world. I've never found the level of intense community activism around health improvement like there is here in our own community. Makes it a very exciting place to think about doing this kind of stuff. And I think the chances of it going further faster here are better than any place else in the country.
All right, so pretend with me here. Pretend you're about to get on the elevator to leave our building, and Barack Obama is on the elevator when you step on, and you've got a chance to give him an elevator pitch on how EMS can impact this healthcare overhaul that the United States is currently debating right now.
One of the things about healthcare is that between fire departments and ambulance services across America, there are hundreds of thousands of trained healthcare professionals that are already in the community. We're trusted in people's homes. We understand medicine. We understand how to communicate with people we've just met. we're good. I mean, anytime you can talk somebody into laying down on a piece of plywood and having your head taped down, and that's in your best interest, that person can certainly talk to folks about, using their asthma medication correctly, making sure they eat correctly after taking their insulin in the morning, and the need to properly strap their kid into a car seat when they get in the car. We are perfectly equipped to really help move healthcare in America toward prevention and management of diseases people have already got, so that we don't have to do that super expensive end of life care, that only keeps people alive for a couple of months at the end of time.
You've been listening to the Alameda County EMS audio podcast. This is your host, Joshua English. You can download this and past episodes of this podcast on our website at acgov.org/EMS. You can also download our iPhone application, which has access to our county protocols, as well as very important phone numbers to contact our hospitals. Thanks for listening. In our next episode, we'll be talking with Michael Gibson of Alameda County EMS's Camp Sweeney Project, a project designed to help kids that are in the juvenile justice system change their lives and start a career in EMS.